Good evening, everybody. Welcome to this session. It was actually billed as a session on IBS, but we had a little spillover from last time on IBD. To recall, we had just touched on the surgical aspects of IBD and said that the surgical, while there are many things common, the surgical approach to ulcerative colitis and Crohn's is a little different. And so we had started on surgical approach to ulcerative colitis, and we had mentioned that in an acute case, where you take up the case for, toxic megacolon, as it were, megacolon, or big bleed, or a perforation, or whatever. Perforation is relatively uncommon in ulcerative colitis, but can happen in megacolon, where there's a big stretch of the colon. There, the patient is ill, and so you do not want to do anything that can be avoided in terms of the magnitude of surgery. And so you do a total colectomy. We also talked about what we do with the rectal stump and give them an ileostomy and then deal with the rectum 2 months later, 6 to 8 weeks later. We now come to the surgical treatment in elective cases. Most of the time, it's because the patient has been a case of non-response to medical treatment, or there may be dysplasia, or they may have gone on to cancer itself. So what are your surgical options for these cases? Nikita, start with you. Are you there, Nikita?
Hello, sir.
Yeah. Did you hear my question?
Yes, sir. What are the surgical options for elective
Elective
procedure?
surgical options in ulcerative colitis. Yeah.
Sir, it depends upon the position of the segment where the ulcerative colitis is more significant.
Okay. So are you recommending a segmental resection?
So most of the time, preferable option would be total colectomy.
Okay.
Ileoanal pouch anastomosis.
Okay. What are the other options?
That's what I read about, sir. Preferably, otherwise it can be
books give you many more options. All right, Praveen, you have anything to add?
Sir, same, sir. Usually abdomen colectomy.
What book did you read?
Sir?
What book did you read to say that your option is total colectomy with pouch anastomosis? That's the only thing I heard.
an article, sir, the Medscape, about surgical management for ulcerative colitis.
That's the only option he gives?
That's the most preferable option they had mentioned, sir. And the colostomies and depending upon patient customization of all the procedures they had mentioned.
That's my question. What is the customization?
If the patient is unstable, then we can directly go for a colostomy.
Only colostomy?
Diversion ileostomy also.
Only ileostomy? Just do an ileostomy and come out?
We have to resect the pathological segment, but the anastomosis is optional, sir.
Okay, so segmental resection is one, you're saying. Okay, what else? You guys haven't read, all right? That's all I can say, or read properly. Okay, even with biologicals, about 25 to 30% need surgery. Okay? You understand that there's still a role. We don't see too many of them here because the incidence of IBD is less in this country. Not that it doesn't exist, but it's less, as we said earlier. Also understand that biologicals make them poor surgical candidates. They're very immunocompromised. These are the options that you have. Okay, a proctocolectomy with ileostomy. Okay, no pouch. That ileostomy can be a continent ileostomy, or you do a total colectomy leave the rectum behind and do an ileorectal anastomosis and keep monitoring under surveillance, keep the rectal stump under surveillance. Now, if you take out the rectum, it need not be a complete rectal excision, but a rectal excision right down to the dentate line. And you can do a proctocolectomy and a direct ileum to rectum anastomosis, the anal canal anastomosis, or do a pouch. Okay. And when you talk about proctocolectomy, you can leave a cuff of the rectal tube above the dentate line and do only a mucosal proctectomy. Take away only the mucosa, but leave the muscle behind. You may take away both the muscle, the whole thickness of the rectum also. Okay. These are the options. So I was going to talk to you and discuss with you what are the advantages and disadvantages of each, but it will probably be beyond an MS level, DNB level, so I won't go into it.
Sir,
Yeah, go on.
Sir, sorry, sir.
The-
Sir, most of the times in ulcerative colitis, they say it as a rectum. Most of the times it will be involving. So if you
Yes.
do only subtotal colectomy,
Yeah, when the disease load, as it were, is removed, okay,
yes, sir.
then when you leave the rectum behind, but you give them maintenance mesalamine, for example, they do extremely well. But you have to keep them under surveillance because of the cancer risk.
Malignancy, yes.
Yeah, and when is that most often seen?
8 years and 12 years.
Correct, 8 to 10 years after the initial diagnosis. So you have to keep them under surveillance, but you will find that they do extremely well. Now, this
Sir,
all go on.
sir, I don't know. Is there evidence for what you are saying, sir? Because
Yeah,
always rectum is involved in only 5% of cases. Rectum is spared. So if you leave the rectum behind, even when you are giving mesalamine or whatever, the fecal stream passing through the rectum will make the inflammation. So I think it is always the rectum has to be removed. That is the
No,
standard teaching.
there is very
I don't
clear.
think it's for- what you say is right for Crohn's, but I don't think it is right for ulcerative colitis.
It is right for ulcerative colitis also. This is a very viable option. Even Western literature, forget about Indian literature, even Western literature says that because the problem seen in the pouch, everybody talks about a pouch. Only very few centers and very few surgeons have the capacity to get away with a pouch. And even though you keep saying in the West that you must go to specialist centers, even there, I'll give you the data on pouch. The problems are very many. So particularly in our conditions where we don't see too many of these cases, very viable. And there is evidence for this. Please look up the risk rates of ileorectal anastomosis in ulcerative colitis. Very clear evidence that there is a role for it. I have no doubt about it. I can even send you some papers later on. Okay, so these are your options. And please note that the proctocolectomy with ileoanal anastomosis without a pouch is a very morbid operation. People have so much frequency and so much soiling in the perianal area and the skin changes that's really, it's just mentioned that it's an option, but not to be done. Pouch is a real issue. Please understand that a pouch can be done both in a 3-phase and a 2-phase manner. It essentially means that each of those steps can be done in either 2 phases or 3 phases. But I'm showing you a picture of a total colectomy. I have about 5 cases of, that's all. We get very few cases to do. I have about 5 cases of total colectomy and ileorectal anastomosis. I do not do a pouch here because of the morbidity that it entails, and our population, I do not think will take it. I haven't seen any major Indian series with pouches. I've looked for it. I can assure you that. And you find that I had only one patient that too recently had a cancer in the rectal stump. Otherwise, I've had them under follow-up for a long time. This patient got it 9 years after I had done the ileorectal anastomosis. I've just done a abdominoperineal resection of the rectum and given her a permanent ileostomy just 2 weeks ago. All right. So continent ileostomy is something that's called a Cox continent ileostomy. This is a cross section of that where you form a valve, and when the ileum here fills up, it puts just like a Nissan's fundoplication. The same intra-bowel pressure goes around this valve and it closes it. So there is no leakage, and the patient puts a catheter through this once, twice, or thrice a day, depending on the comfort level, and gets rid of the liquid contents of the ileostomy. But look at this. I've been involved, not in this country, but when I was abroad in a few continent ileostomy cases. Revision is required in 70% of cases. Each patient ends up with 3 operations within 14 months. That's the kind of data that you have in this. So basically, continent ileostomy is not much of an option. So you end up with an end ileostomy. Okay. Pouch surgery. Can you see it can be done? I'm not saying no. JRS pouch is preferred to W pouch. W was very popular when we were training because people thought that it had a larger capacity, but they found that the problems with it were much higher. It was not emptying well, and the incidence of pouchitis was very, very significant. Okay, pouch length is something that you need to focus on. About, I think they call it 8 to 9 centimeters in your S or J pouch configuration would be an ideal length. You have a 10% chance of a leak, get fistula, you can get abscesses, but pouchitis is a very real issue. Cuffitis is an inflammation of the rectal cuff that you may have, slightly different from pouchitis, but these are very real issues. And if you're not doing it on a regular basis, which I don't think any surgeon in India is doing, then there is a real issue with this. And that is the point I'm making to say that it would be much safer for the patient to give them an ileorectal anastomosis. Okay. And pouchitis is quite crippling. And so what you need to do for that is to consider 2 or 3 differential diagnoses. It may be a bacterial infection. It may be a recurrence of the ulcerative colitis. You must actually call it ulcerative ileitis. We have a concept of backwash ileitis. And so the terminal ileum, which you use to form the pouch, again, can have inflammation there. You end up with frequency, urgency, and cramping pain. The differential diagnosis includes infection, ischemia, and it could be Crohn's. As I kept saying, in about 10% of cases, there is an overlap. So you start with a 2-week course of antibiotics, try to get the probiotics given, then treat them as inflammatory, give them biologicals. When you do that, most of them settle down. But if they don't, you have to have an option of taking down the pouch and giving them a permanent ileostomy. Please look at the incidence, 40% early, 80% lifetime. So I know that I'm going to ask Ravi's inputs on this. We may have a difference of opinion on this, but the point is that the morbidity associated with the pouch and the maturity with which one has to face it, I don't think our population has that as compared to the Western population who understand a real informed consent and go through with it. Here, there may be an issue. Ravi, your comments, please.
Yeah, so the pouch failure, as you said, is about 30%, sir. The over a lifetime of this one, if you look at it, 30% is which means, and majority of the pouch failure is due to undiagnosed Crohn's disease, and then pouchitis is the second cause, and then pelvic sepsis and pouch malfunction. So I think the rate is very high. Even when I heard Victor Fazio, who was one of the pioneers of pouch surgery in Cleveland Clinic, his failure rates were also about in the 25 to 30% range. And Roger Dozba from Mayo Clinic, again, very high, huge series. Again, pouch failure is quite high. And from our own Hope Hospital in Manchester, I think we had about 150 pouches, and there were significant failure rates. And I think the main cause is because the spectrum of ulcerative colitis and Crohn's disease there is a huge overlap, as you said. The intermediate, I think pouch works very well for ulcerative colitis and intermediate colitis, but not so well for Crohn's. And if the initial diagnosis by pathologist or the presentation is wrong, or I won't call it misdiagnosis, but probably late diagnosis of Crohn's, that is the commonest cause of failure. And the pouchitis very sick is on the 2-stage and 3-stage pouches, as you mentioned again. It is generally considered to not do 2-stage pouch in patients with ulcerative colitis because of the fact that you have to let them adapt. But in patients with the familial adenomatous polyposis and things like that, there you can do a 1-stage or a 2-stage pouch. But generally with the ulcerative colitis, you tend to do at worst 2-stage or definitely 3-stage pouch. And I think generally these are the things. And again, pouchitis is a very significant problem. Even with the advent of probiotics and biologicals, the problem has not gone away.
Indian experience, Ravi, have you done any pouches in India?
India Manila, sir. I have done it in, I have not done it here.
See, this is my experience. I don't know what as I told you, I have 5 or 6 total colectomies. None of these 5 or 6 patients had the kind of socio-economic background to understand pouch and the morbidities that go with it. And that is the point I'm making. I'm giving a very practical solution.
Okay.
Particularly in our country. That is why I'm recommending that I would recommend without any kind of hesitation or limitation, an ileorectal anastomosis, keep them under follow-up. One may argue that they don't come for follow-up. May be true, but if you take the money out of the equation, they'll come. All these people who are low socioeconomic, I would do free surveillance sigmoidoscopies. They've all come for follow-up. And as I said, one patient developed a cancer, and 2 weeks ago, I did a rectal excision for her. So that is as far as the pouch and thing. The point I'm making to our students here is, it looks very nice and it's not even bad. It's all very good. Whatever figures Ravi quoted, as you see, are total conformity, what I have mentioned. But you have to look at your population, look at your situation and see what is best for your patient. And those situations may change. When you guys become consultants, you may come across some very sophisticated, educated person who can take it and you can then offer it to them and do it. But the limitation there will be that you will have very little experience. It needs a lot of experience to get a success in a pouch surgery. So you have 2 choices. Either say, look, you want to go somewhere, you go. I don't think in India there's anybody with a large series, as far as I know, at least large published series. So you have to either send them abroad to some center, or say, please, I think this is the best. This is where I do the best for you, and so accept an ileorectal. That's my stand. Ravi, your comments on that?
I agree with you, sir. I'll look at the papers that you sent.
Yeah.
But the major issue I feel is that the rectum being there, the symptomatology of tenesmus and bleeding per rectum and things will persist even though you give them treatment.
Yeah.
Whether I don't know what your experience
my
was.
very limited experience of 6 cases, this has not been an issue. They actually do very well. Sometimes if it plays up, I give them antibacterials, metronidazole mostly. They settle down. If that doesn't work, I'll give them a course of steroids and it always settles down. Okay, almost always it settles down. So it's not a big issue.
Yeah. Otherwise, what you said, I have heard Victor Fazio, who was one of the largest series of pouches from Cleveland Clinic, and Roger Dozva. I think I think it is a surgery which is to be done only in very high volume and specialist centers. And because I think it not just the surgical issues, I think the support system and then all these things which you need will be available even in England. For example, there are only maybe one for Scotland in Edinburgh. And
in my time, there are only 3 centers doing it.
In Hope Hospital in Manchester, and then the St. Mark's Clinic.
Yeah.
So I think there were only 3 centers which were doing it.
Yeah. Correct. Oh, okay, my time it was the same thing, yeah. All right, now we go on to the surgical treatment of Crohn's. And as I said, this is a disease that extends from mouth to anus. And so you end up with different operations offered for upper GI, ileocolic disease, colonic disease, and perianal disease. Upper GI is extremely rare. I haven't seen surgery for upper GI, even though I've seen upper GI Crohn's. But the main one would be ileocolic disease, some colonic disease, and fairly common perianal disease. So we need to look at the basic pathology. The treatment for each of those, depending on the pathology, surgical treatment is different. So you find that all the pathology in Crohn's can be sort of summarized into these four things: inflammatory stricture, fibrotic stricture, penetrating disease with abscess, and penetrating disease with fistula. Very simple, very simple. So as you can see, depending on the pathology, you can expect to have a different kind of treatment that you have to give. And for inflammatory stricture, you do a resection anastomosis. Okay, it can be laparoscopic, it can be open, it can be robotic. That's whatever. The point here is that you do not do a stricture plasty for acute inflammation. That doesn't work. The big question in Crohn's and the controversy has been, you take away all the macroscopic disease, and then you may still have microscopic disease at the point of resection. When you anastomose, will you have a higher leak rate? The answer is no. Okay, people have done that. So obviously, macroscopic inflammatory disease is something that you aim to remove. It is very important here because you cannot remove too much of the bowel, because you may end up with a short bowel syndrome. The average number of operations on a Crohn's patient is 2.3. All right, so 2 to 3 operations they undergo in their lifetime. And so you cannot be too aggressive when you do a resection. All right, so if you have a fibrotic stricture, then you have a choice of stricture plasty as well as resection. Okay, if it's a short segment, not too many strictures, you can resect it. You won't lose too much length. So you can resect it and do an anastomosis. If these strictures are far apart, for example, it is known that it is good not to have more than 3 anastomoses, 3 resection, 3 anastomosis. Anything beyond 3 anastomoses, the leak rates or morbidity rates are higher. So if you have to have several strictures where you may end up with more than 3 anastomoses, try and combine the strictures and do a longish resection. Much better that way than to have more than 3 anastomoses. If you have a penetrating fistula, for example, okay, you can resect that area, but what we mean by sparing the target organ is that if it has gone into the bladder, for example, ileocystic anastomosis, you don't have to be too aggressive on the bladder side. You can just take away that fistulous tract and leave that, but on the bowel side, which is the primary source of the disease, you have to have a proper resection. That is what is meant by saying spare the target organ. And if you have an abscess, you need not always have resection. Try a percutaneous drainage first. If that doesn't work, too many loculations, inter-loop abscesses, which you cannot manage with percutaneous methods, do an operative drainage. And if there's a lot of active disease, do a resection. Then the question arises, when you do a resection, should you anastomose or not? That is taken on a case-by-case basis. If there's a lot of sepsis, a lot of malnutrition, you choose to give an ileostomy and do an anastomosis later. But if you feel that the patient is reasonably well preserved, not too much soiling of the peritoneum, then you end up with a primary anastomosis after drainage of abscess and resection. Okay, so this is the general principle. But I can tell you that one of the most difficult operations, most difficult resections and dissection that you can do in the abdomen would be Crohn's. It's always a challenge. And because we saw so many of them when we trained abroad, we learned a lot in the techniques that are used to unravel, adherent loops of bowel, dealing with interloop abscesses, and doing a relatively safe resection without doing too many enterotomies accidentally. Ravi, your comments.
Yes, sir. I think other, I don't know whether there is definite literature proof for this, but diversion of fecal stream seems to keep the disease quiescent. So, if, for example, if you have the significant segments of ileum that is, or small bowel or large bowel that is involved, even if you do an anastomosis, you can protect it by doing a loop ileostomy or so prior to that, and then after the patient has settled and nutritionally better, and you can consider closing it. I think apart from that, whatever you've said is absolutely right. The onus is on as little resection as possible. It is not like cancer where you have to have a margin of healthy normal tissue at both ends. You can, and as sir said, it is very right that even if there is microscopic disease at the two ends of the bowel, it doesn't contribute to anastomotic. So you don't have to remove this onus is on as little resection as possible.
Yeah. So I won't go into the details of these, but please note that when you do strictureplasties, you have three options. Okay, the Mikulicz strictureplasty, which we normally do, Finney, the same thing that we do for pyloric stenosis, nothing different. And in Crohn's, when you have longish strictures, you have this option called Michelacci. I have never done it. I've not even seen it being done, but it has been highly recommended when you have a long stricture and you want to preserve the length of the bowel. Any experience for you on this, Ravi?
I have only seen it in by Adrian Bianchi and Manchester Children's Hospital in kids with necrotizing enterocolitis and childhood Crohn's.
Yeah,
he would do this procedure, but I think generally I have not seen much of it in adults.
right. So, Sanya, can you think of a few contraindications for this? For strictureplasties?
If it is involving
I've already mentioned one, an acute inflammatory disease, inflammatory mass, you don't do it, yeah, go on. Others?
yes, sir. If it is the length involved is bigger, sir.
Okay.
And if even despite doing the stricturoplasty, if the lumen is narrow, like
Yeah, okay. Okay, so this is it.
Okay.
If you have bleeding, active bleeding, apart from the inflammatory mass, which I had already mentioned, bleeding, if there's a fistula, there's no role for a strictureplasty. And if there's suspicion of cancer. Okay, these are the contraindications. Suspicion of cancer, fistulation, bleeding, you have to have resection, no strictureplasty. These are my own cases that we have done. You can see the deep longitudinal ulcers that you have and the so-called creeping mesentery onto the bowel. Okay, I've done a segmental resection of the ileum in this case. There is a lot of talk about the role of mesentery. Okay, and it's not proven yet, it is still controversial. People say that you have to take the mesentery of that segment. Otherwise, there is a lot of pathology associated in terms of activity of the disease if you leave the mesentery behind. Like in this case, we have taken the mesentery close to the bowel here, and there's mesentery left behind. If that happens, people say that there may be a higher recrudescence of the disease, but that has not been decisively proven yet. All right, so that is about the ileocolic disease. The colon and rectal disease, nearly the same. Okay, but please note that there is no contraindication, absolute contraindication for any of these things in Crohn's, even though the classical teaching and logic tells you that because it's a transmural disease, if you take out only the mucosa and then put the pouch to the anus, the anal canal, then you may have a recurrence. We discussed when we were doing ulcerative colitis, the problems of the pouch is because of Crohn's disease. So you may say there's an absolute contraindication for doing pouch. But I have seen literature, surprisingly so, where people have done pouches for Crohn's also. And I think that this it's become a relative contraindication after the biologicals have come into being. Okay, that's what I feel, even though I'm not sure why they do it. What is important classically, going theoretically, you wouldn't do a pouch, you wouldn't do only mucosal excision, or you wouldn't do only segmental resection for Crohn's, because it is an extensive disease. And even though a segment may look normal now, a few months or a year down the line, you may have activity there and then a problem again. But those who do it, I guess, do it with the confidence that the present day biologicals will probably deal with the disease. Your comments, Ravi?
Yeah, I agree. I think the one is, I think those the higher series that I quoted from Cleveland Clinic and Mayo Clinic, informed consent forms an extremely important part. And if the patients are aware that there is a 38% chance of pouch failure in patients who have had Crohn's and who have gone for pouches, and if they are willing to take that chance, then you do it. And then there is a very good series from France, from Hospital Salpêtrière, I forgot the name of the surgeon, who tends to advocate pouches for even for Crohn's disease, and his series, the results are extremely good. So, but he's an outlier rather than the standard. I think generally, pouches are, ileorectal is a much more of an option in Crohn's, and then if the patients want pouch, especially in bad perineal disease, which is now offset by the onset of the biologicals, which seems to have an exceptionally good result for perineal Crohn.
Correct.
Perineal disease. So I think that has made the chances of pouch surgery in Crohn's disease much less of an option.
Yeah. So rather than confuse our students in the exam, if they ask you what would you do, then you would say, sir, theoretically speaking, should avoid a pouch, should avoid only mucosal excision, and avoid only segmental resection, because it's a transmural disease. Okay, but there are surgeons with large series, where it has been done, and as Ravi mentioned, an informed consent about a higher degree of failure has to be taken from the patient before doing it. Am I clear?
Yes, sir.
Somebody say yes or no.
Yes, sir. Yes.
It's very important. It's very important. Okay. Perianal sepsis is a very, I'll have to go through, because I have to finish IBS after this. I don't think I want to take it on to the next class. I'll keep it short. I'll keep the IBS thing short. The perianal sepsis is a very vexing problem in Crohn's. I have seen some very few, okay, maybe 8 or 10, but really crippling disease with young ladies with multiple perianal fistulae, which is extremely embarrassing and extremely uncomfortable to the patient. And that is something which is vexing. And as Ravi rightly pointed out, the biologicals seem to have made a big difference. They seem to heal it very well. And as he said, in terms of fecal stream activating the disease and diversion of the fecal stream, deactivating the disease, as it were, or healing it, it's very true for perianal disease. Okay, while you do not do a diverting colostomy very easily, if you have big problems with getting healing in perianal disease, kindly have a low threshold for doing a colostomy. You can assure the patient that will be temporary and not permanent. But what is very important to understand is that you do not do a very liberal, aggressive drainage like you do in cryptoglandular disease. You will end up with incontinence and destruction of the sphincters if you do it. The disease itself and the infection that goes with the disease, that itself can damage the sphincters. You cannot, as a surgeon, add to that damage. So it must be only to drain the pus, to take away the toxemia and the pain that is associated with it. Conservative drainage, liberal use of cetons. If you find an internal opening, please remember that that's not a cryptoglandular opening below the dentate line like you see in our conventional perianal sepsis. This is Crohn's sepsis. It will almost always be supralevator. And so you end up with a high fistula, use a ceton, intensive medical therapy, including biologicals. If that fails, diverting colostomy in a very, very difficult case, I have never had to do it so far. I have not even seen it even in the West. You can do a proctectomy to take away all of the disease if you just cannot control the perianal disease. Okay. Ravi, your final comments before I go to the next
I
topic.
agree with you. I've had 5 patients here in India whom I have done, who we have given adalimumab and cetones, as you said, and they've all done very well, and we have managed to preserve their rectum. And now I have to do 2 diverting colostomies, and we have reversed it also, and they are fine. But I've had the opportunity of doing 1 proctectomy in a young chap, 21-year-old, who had such bad Crohn's, and he had absolutely no sexual function, very bad rectal Crohn's and anal Crohn's. I had to do a proctectomy. His quality of life improved so much, even sexual function returned, bladder function returned, and he did very well. But as you say, it is extremely rare that you have to do that.
Yeah. Okay, any questions or comments before I move on to IBS? Sanya?
So just about that pouch that we
Yeah.
were talking. So given the statistics that it has so much of problems and all that, can we directly advise the patient or give an option of ileostomy? Or will the ileostomy also have
No,
similar issues?
ileostomy will not have similar issues, but they have to
Yes,
learn to live with the ileostomy. But as
Ileostomy.
professionals,
Yes,
it is our duty to give them all the options. It's now
Yes, sir.
considered a joint decision. And
Yes, sir.
whenever I have done these cases, I always tell them these options are available, but these are the problems. That is why
Okay.
I would recommend this. I would
Yes,
recommend
sir.
this, but I will go with what you say. That's my standard informed consent process.
Okay, sir. So the recommendation would be pouch only, no, sir?
No.
Ileostomy.
Pouch is an option. My recommendation is ileorectal anastomosis.
No, sir. In case if the rectum is also involved.
Yeah, even if the rectum is involved, that's the point I've always made. Even if the rectum is involved,
Okay, sir.
okay, if you are prepared to live, because they have to either live with the surveillance and treatment of the rectal disease or live with an ileostomy.
Yes, sir.
That is their choice. So I tell them these are
Okay,
the
sir.
options.
Okay, sir.
These
Okay.
are the options. So most people,
Yes, sir.
all the 6 that I have done, did not want an ileostomy.
Okay, sir.
So I've done an ileorectal, and I've treated the disease in the rectal stump, and I have put them under surveillance.
Okay, sir.
That's
Okay.
what I've
Yes.
done. But if somebody says I don't mind an ileostomy, I would happily do an ileostomy.
Okay, sir. Yes.
This is more philosophy than medicine, honestly. And as I said, most of the patients I've seen have been in lower socioeconomic strata. And so I did not think they were candidates who would really, definitely not a pouch. They wouldn't stand a pouch, but do not tolerate an ileostomy. Okay. Yeah. All right, Ravi, your final comments on that. What you would tell a patient?
Yeah, I agree with you entirely that I think the pouch is now, especially in India, the disease volumes are so low. I don't think anyone would recommend doing pouch in India. But even in the West, I think a significant portion of them will happily have 1-stage procedure, which is a pan-proctocolectomy and ileostomy.
Yeah.
And if they so wish, then they are sent to specialist centers for pouch, with the understanding that the pouch does have a 20% pouch failure rate and 38% reversal and re-surgery and things like that.
Okay, we switch gears and go on to irritable bowel. I'll try to finish quickly, but I may overshoot by 10 minutes or so. But I think we should finish it this time and not carry it on to the next one. Okay, irritable bowel.
Not worth carrying.
Not worth carrying. Yeah, I'll finish it. We need to understand what it is. The newer buzzword, which is really making huge inroads, is the so-called gut-brain interaction. How is it diagnosed? There's a lot of confusion in this, and I hope to give you clarity, because I've done a lot of reading about it, not now, not because of this class, but well before that, for years. Because one of the main things I'll tell you is that we do not have the gumption, as it were, the guts to tell the patient that it is IBS. And that is something that's very important in treatment. You must tell them it is IBS. And how is it best treated? We look at it one by one. Please understand that there is now a clear definition of IBS. There is what's called Rome criteria. Okay. Any of you know what the Rome criteria is and when it started? It's a consensus of experts in the field. Any of you? Have you done reading about it? Nitya? You've been very quiet.
The Rome 4 criteria tells the definition about
When did it
irritable
first
bowel.
start? When did Rome 1 come out? When was even
that literature historical part I have not read.
Anybody? Anybody? All right. Okay. Go on. Somebody is trying to answer. Nikita.
No, sir. No, sir. History part we did not read, just the criteria.
All right. Okay. So please understand that it must be at least once a week, one day in a week for the last 3 months, associated with 2 or more of the following criteria related to defecation. There must be a change in the frequency of stool. It can be either constipation or diarrhea. And there must be a change in the appearance of the stool. Okay. Abdominal bloating and distension may also be there, but need not be there. Okay. Abdominal bloating. There are other associated things which are not given as much importance to the frequency and appearance. There may be one more criterion, just like abdominal bloating and distension, relief of discomfort after passage of stools. Okay. All these in the absence of what are called, flagging, disease, as a, the red signs as they call it, which flags organic disease, which denotes serious disease. In the absence of those, if you have pain once a day for the last 3 months, associated with these 2 changes in the bowel, then you call it IBS. It's a positive diagnosis and not necessarily a diagnosis of exclusion, even though we have to exclude some important diseases and we'll learn about it as we go along. Now, functional disease is something that we have always said. What does it connote to you, Nikita? What does functional disease mean to you?
Sir, it affects the routine usual function.
Okay.
And also the function of the patient, sir, like day-to-day activity.
Okay. But what is it? How does an average doctor like you and me, how do you look at functional disease?
There is no organic pathology for a functional disease.
All right. And is there anything else? What do you think that the patient is doing when you say it's functional disease?
It's something in the brain. It's something to do with the mind.
The mind. You may almost think he's malingering.
Yeah, sort of.
Sort of. Yeah. All of us, including me. That's an important concept to have. We almost think that the patient is putting it on. Okay. 40% of GI consults have this component. Please understand. There are 33 disorders, functional disorders associated with the GI tract. It's a huge number. And about 15% of it is IBS. There are many others. But the important change in our thought is this. They now call it a disorder of gut-brain interaction. Okay? And so you do not think, there may be no organic disease that you can establish, but you do not think that there is any kind of malingering or the patient putting it on. There is an underlying pathology which is ill understood so far, even though a lot of research has gone into the field. And those disturbances, those disorders have the following underlying pathophysiology: motility disturbance, gut hypersensitivity, mucosal function, gut mucosal function. Very important nowadays, gut microbial environment and altered central nervous system processing. This may be considered somewhat psychiatric or somewhat psychological, but please understand that all these things have some scientific substance. They have proven in many, many studies changes in all these aspects that we have said. So we should, as doctors, the message is very clear. Don't think of it as some kind of a, psychiatric issue which you should be dismissive about. You must look at IBS, however difficult it is, particularly for surgeons who are, who are famous for seeing the pathology with their eyes. Physicians don't see their pneumonias, they don't see their heart attacks, but we keep seeing our cancers and our ulcers. So for us, when we get these patients, you must train your mind to make sure that there is a pathology going on, even though we don't understand it completely. And that brings in the compassion in your treatment. And compassion is a very, very important part of your treatment. I won't bore you with this slide and the next slide, but the important thing I have to show you is that there is a clear scientific evidence about the change in the microbiota, in the intestinal flora, as well as the impulses from the gut, from the brain to the gut, which involves the thalamus, the prefrontal cortex, and the cingulate cortex. All of these areas are involved in some way, sending signals to your gut through the neurohumoral mechanism, and many, I'll show you in the next slide, many transmitters. Don't even try to read all this. I'm just telling you to make the point in a pictorial fashion that there are many transmitters and chemicals that are involved. All these have been studied, and abnormalities in all these transmitters have been established. Even though their exact role and what you do with it is not known yet, this kind of a gut-brain axis is a reality. The changes in motility, changes in microbiota are a reality, and hence your scientific treatment, there's a little limitation in that it's not as scientific as some of the other diseases. But to the extent possible, the scientific treatment of IBS involves, apart from the kind of compassionate understanding care, trying to moderate motility and the gut flora. Okay, that in essence is about IBS. So DGBI, which is the disorders of gut-brain interaction, is not just IBS. It's only one. I told you there are 33 diseases, and IBS forms 15%. So there's another 85% of disorders which can do all that. Can any of you, have you read about it, or can any of you enumerate it? Sanya, we'll go to the registrars. Is Ainas there? Did you read about it, Ainas?
Golden silence.
Or golden silence. So let me just go through, instead of a discussion, I'll make it a lecture. And I'll accept the fact that, 80% of it you'll have forgotten by tomorrow. I wish you don't forget. Yeah. Okay. The thing is, all these areas are involved in this gut-brain interaction. Okay. Esophageal, gastroduodenal, intestinal, GI pain of the whole thing, of the whole GI tract, gallbladder and sphincter body disorders, anorectal disorders. If you read up the Rome Foundation documents on this, you will learn this. All this is taken from the Rome Foundation. As you can see, the references down here. Disorders of the gut-brain interaction, definitions, every one of them. In addition to this, they have given another set of issues in children, because we don't treat children. I have not gone into it at all. Okay, so please understand that you have all these systems that can be affected by the DGBI, and there is an overlap. That is another important thing. IBS is not pure IBS. You can have non-ulcer dyspepsia, that is the gastroduodenal. You can have biliary dyskinesia, that is the gallbladder. You may have excessive sensitivity to visceral pain. So you can find that all these things overlap. And what is even more challenging for us as clinicians is that there's an overlap of symptoms between IBS, IBD, GERD, and functional dyspepsia. So you need to know what is organic and what is DGBI. That is the important thing that you have to do. You have to rule out some serious disease, and only then, if they fit into the definition of IBS that I mentioned, pain once a week for 3 months at least. Once they do that, in the absence of danger symptoms. If you do that, then you can confidently say it's IBS. And I started in the beginning, I'm saying it again, and I'm going to say it again in the end. You must tell the patient that this is IBS. because that seems to help them to come to terms with it, and it has shown that that definitive diagnosis helps them to cope with the symptoms. Now, this is the history of IBS. That's why I would like you to understand this. You have to know that Manning was the first person to talk about it as long back as 1978, but he ignored the presence of constipation in IBS. He never included that. Cruz in 84 had a very complex definition of the disease, which was clinically too difficult to understand. That's why they formed the Rome Consortium, as it were, a group of specialists who are specialist interest. And it has gone through 4 versions since 1992. The latest one is 2016. Okay. Please note Rome 3 also, because I'm going to talk about Rome 3 and Rome 4 in the Indian context as we go along. And they not only defined the IBS, but they also gave you subtypes. And understanding the subtypes is important because it has implications on treatment. Okay. So subtypes are basically dependent on the stool type. Well, as disgusting as you may find in this, but there is what's called a Bristol stool chart. And it's not just theory, because as you know, as surgical gastroenterologists, even though we were general surgeons, we have been, because we do a lot of GI surgery, we are termed surgical gastros. And then somebody forgets that we are surgical, and a good part of our practice will be medical gastro. Okay, and it will be IBS. Ravi, your experience in this?
Yes, sir. I think I agree. There is a significant portion of patient. I think
Sorry, go on.
The this one that you said, very important, where you have to label the patient as IBS, but you have to ensure that you have ruled out all organic causes for the similar complaints, and ensure that only after that, if you label them, it is okay, because the patients will accept it and you will be able to treat them. Right. And the other thing is to try and when we come to treatment, you will probably stress that it is important for them to be as relaxed as possible, because stress does tend to exacerbate the symptoms.
Yeah, we will go into the minimum investigations that you need to. Shrikant, your experience, you see a lot of IBS patients?
Yeah, I've seen.
Yeah.
But that's what they're diagnosed by exclusion, but I didn't know there are so many subtypes.
Yeah, there are many subtypes. Yeah. Okay. So you find that there is a stool chart. Look at you will see it's actually pictorially represented as well here. So it tells you which one is which type. So the basic types are constipating type, the diarrheal type, the mixed type, and the U is uncharacterized. It doesn't fit into any of these. So these are the types of IBS that you can see, and it tells you which of these types has which stool it is. But basically, it's quite understandable. Some of them constipate, some of them have diarrhea, some of them have constipation at some times and diarrhea at some times, and some of them nothing doesn't fit into any of these. So we have seen all these types in our practice, and this diagram basically tells you that it can vary with time. Okay, it tells you bowel diagnosis can change over time, and it can be constipating this today, and then 3-4 months later it can be diarrheal. Sometimes there may be more bloating, sometimes there may be less bloating, things like that. Sometimes there may be pain, sometimes there may not be pain. It is not easy to put one person into just one category. With time, it may change. But what is important is, as Ravi mentioned, that we have to rule out organic disease, which means you have to know what the red flags are. As I mentioned, what are the danger symptoms? We have gone through this many times, so we'll have to get one of the youngsters to. Now, Samir, what are the danger symptoms that tell you there is something serious going on in the GI tract? Are you there?
Yes, sir.
Go on.
Sir, bleeding, sir, melena.
Yes. Bleeding, rectal bleeding,
Yes.
melena, right?
What else, sir?
Vinod, quickly.
Abdominal pain and
pain is not. I told you, no, pain is a characteristic of IBS. Yeah.
Alternating constipation and
sorry,
alternating with constipation, alternating with diarrhea and
okay. And there's one more definition, rider for that.
Tinnitus.
Recent onset.
Yes, sir.
If
Recent.
it's going on for 6 months, it cannot be something, recent onset.
Yes.
Yeah, go on.
Yes,
Then,
sir.
okay.
Tinnitus.
No,
And
not necessarily. Okay.
yes, sir.
Go on.
There is a recent weight loss of around 4 to 5 kg.
Good. Okay. Older age group.
Yes, sir.
Anemia, blood in the stool, unintended weight loss, nocturnal diarrhea. People get up 3-4 times at night to go past stool. That's not gut-brain axis. Okay. Family history of IBD or cancer, recent change in the bowel habit. You mentioned change in bowel habit, and when you examine a bowel mass. So it's very important to listen to the patient, to get a good history and ask all these things, give a proper examination, make sure there is no rectal mass or an abdominal mass. Okay, that's a very important thing. And there's an entity called post-infective IBS. Have you guys heard about it? Yes or no? Nitya?
No, sir.
Sir, any recent surgeries or I have heard about this thing
All
like
right.
patient having any.
Okay. It is not surgery, it is acute enteritis. Somebody has a diarrheal episode, very common in this country. Okay. And about 10 to 15% of them end up with what's called post-infective IBS, which lasts for the next 4 to 8 weeks. It's a temporary phenomenon.
Shortly.
And shortly. But you'll get a very clear history of a recent enteritis episode, diarrheal episode. Risk factors, young females, severity of the enteritis, and stress around the episode, mental stress. So you need to treat them as IBS, recognize. This is very common. I've seen it clinically. I've not done a study on it, but it's so common that I think it's worth doing a study. Post-infective IBS is something that happens, so be aware of it. All right. So the workup, we come to this. I told you it is very important to take a good history, do a good clinical examination, but this is the minimum that you have to do. Okay, CBC, creatinine, CRP, inflammatory marker, which will not be high in IBS. Fecal calprotectin, this is mentioned in the literature, but it is so uncommon that I don't think we do it routinely in this country. There is a lot of controversy about colonoscopy. The Rome criteria says that 98% of colonoscopies in this population is negative, so you don't have to do it. But the Japanese criteria says that I think it's good to do it, even if it is negative, basically because it proves through visceral hypersensitivity. This I have found to be very useful clinically, because you do a sigmoidoscopy or a colonoscopy, they are very, very uncomfortable even with very good sedation. Whereas a person who has, say, IBD, for example, will tolerate it much better. That is what is called gut hypersensitivity. And it's our practice also has shown that the Japanese guidelines are probably good. So I always do, particularly if somebody is over 45 or 50, before I tell them it is IBS, I always do a colonoscopy. I don't always get a calprotectin unless I see something on colonoscopy. If I see inflammation and ulceration, then only I do it. But this I routinely do. CBC, RBS, creatinine, CRP, I do an LFT also, which is not mentioned in the literature, and I do a colonoscopy. This in the presence of a normal clinical examination. All right. I label them IBS. And
Sir,
go on.
I think I'm sure you find this also, but there is the scope, the bowel grips the scope a lot in these patients,
Yes.
which I think gives you and sometimes I wonder whether diverticulitis is a kind of an extension of IBS, because over a period of time,
Yeah.
long-standing IBS may lead to diverticulosis or diverticulitis later.
Yes, it is a recognized theory for formation of diverticulitis. When you have a lot of spasm, all right, so much spasm that there are weak points in the muscular muscle wall of the rectum where the blood vessels enter the rectum. And that's why you get outpouchings of the mucosa, because of the increased intraluminal pressure that happens. Yeah. And, IBS is the same thing. So it could be, as you rightly said, it could be an extension. So as I said, listen to the history patiently, very difficult for surgeons, particularly a guy like me. Okay, I sit there in the clinic. I have to make sure that my body language is not showing. I should not feel the irritation, but sometimes I do feel the irritation, I must confess. But I make sure that I listen to them patiently. That's what helps you give a rapport. If you show your irritability, if you show your impatience, you can't have a rapport with the patient. So do a full physical, review the basic test results that we mentioned in the previous slide, give them a diagnosis. After you do it on their second or third visit to me, having gone through all these tests, I tell them you have IBS. Okay, and I always tell them it is either stress or personality related, and it is the mind that is driving the gut. Most people would not accept that. They never accept that they have stress. I said, then I don't push it and stuff it down their gullet, as they say. No, okay, maybe you don't have a stress, but the issue is this. So please try to make sure that you take enough physical exercise, take some time off work, get a balance, work-life balance, right, and things like that, and then set medical treatment. Okay, what is the medical management?
Any role for upper GI endoscopy?
Not routinely, unless they have non-ulcer dyspepsia. As we mentioned, a part of it is esophageal and gastroduodenal. If they have heartburn-like symptoms, they may even complain of chest pain. They may complain of nausea and bloating in the upper abdomen. If they say all that, yes, I do an upper GI. But in a classical IBS, most of it is lower GI symptoms, and we don't routinely recommend an upper GI. Okay, so this is something that you must focus on. I got it from the Japanese guidelines, which are, I think, very, very nice. Please note that several things have been tried. And when there are so many things, as I keep on saying, if you have too many options, none of them is really good. But if you have a really good medicine or a really good option, the whole world would adopt it. Okay. So the ones in the yellow are the ones which have strong evidence for successful action or helping. The ones in the white are so-so. Not that they're useless, but they don't have such strong evidence. So bulking agents like plant husk, antispasmodic agents, okay, 5-HT3 antagonists, we call it IBS, which is used in IBD diarrhea, the diarrheal type. You use things like mosapride, which is HT4 antagonists in constipating type. What happens if you have the mixed type? Whatever is predominant, you treat it. If diarrhea is predominant, use it with ramosetron, treat it with ramosetron. If constipation is predominant, treat it with mosapride. Psychotherapy is something you can actually recommend, but do it very gently, because some people get very offended in this country when you say you must get psychotherapy. Lot of other things have been advocated. I never advocated diet. I only tell them eat a lot of fruits and vegetables, eat whatever else you want that keeps you happy. I believe exercise is extremely important, not only for helping IBS, but also for their general fitness. So I advise them that they should have at least 1 hour of aerobic exercise, where their heart rate goes up 50% more than the resting heart rate. That is the definition of aerobics. Avoid alcohol and smoking. I'm not a great proponent of that. Antidiarrheals, if the diarrhea is very bad, for a short time, not for a long time, you can use anxiolytics and tricyclic antidepressants as well. In a very severe case, nowadays, I have been using a combination of an antispasmodic and an anxiolytic. There are many such combinations in the market. And I use not tricyclic antidepressants, but some other antidepressants, newer antidepressants, anti-serotonin uptake medications, and you can use that. Okay. So that is as far as the medication is concerned. And I also tell them my primary job is to make sure that you don't have a serious disease. And I tell them, please take heart that is the case. And so don't expect magical treatment from what we give. Okay. There are a lot written about probiotics, symbiotics, and prebiotic. Okay. What is the difference between these three? Anybody knows about it? Nikita?
Sir, FMT is fecal transfer, sir. Fecal microbiota transfer.
Correct.
Probiotics are actually
probiotic, prebiotic, and symbiotic. Symbiotic. What is it? Should I give you the answer, or I think you should see, this is IBS is a medical gastroenterology topic, but surgeons must know about it. Okay, you guys asked for it. So, but we haven't read about it. All right. So I know I can spoon feed you, but I won't. Go ahead and check what the definition of probiotic, prebiotic, and symbiotic. Okay, and put it in our group. Let us see. Do it tonight. It's very easily available in the on the internet. Okay, so you have many studies, and all of them come out. The meta-analysis tell you that probiotics and fecal microbiota transfer help a little bit, not a lot. These are the bugs that really are helpful. Dosage is not finalized yet, and so more studies are needed. Is the latest conclusion 2024. Okay, the fact is, that's why, because it's still very debated. I certainly do not recommend FMT. I do not normally recommend either probiotics or symbiotics as well. But if it's very difficult and nothing seems to be working, just to buy time, I give them some probiotics and ask them to come back in a month. Okay, that's what I do. The Indian scenario is a little different. I always look for Indian papers for whatever subjects that we study. And here it shows that post-infective IBS may show a degree of malabsorption. Malabsorption is not a feature of IBS or the gut-brain disease. But in India, this paper by one Ghoshal says that there is a higher incidence of malabsorption after post-infective IBS, which is tropical sprue. And so when that happens, even if it is IBS, you can see that there are a lot more tests that are recommended. That is recommended only for refractory IBS. There is no clear definition of what refractory IBS is. But if you treat IBS for 2 to 3 months and they're still not better, then you may have to consider these extra tests, basically for malabsorption and tropical sprue. At this time, I strongly recommend that as surgeons, you be good enough to refer them to medical gastroenterologist. You can do it even earlier, not a problem. I have a very low threshold for referring them to medical gastroenterologist, and I'm sure my good friend, friends, correct, and I'm sure my good friends, medical gastroenterologist, curse me for sending them perhaps. But to be fair to myself, I don't send them straight off. I really do treat them for 2 to 3 months, and I find that I'm not making any headway. Then I send them to the medical gastroenterologist. Now, you find that the Rome 4 criteria differs from the Rome 3 criteria in terms of getting rid of bloating. Okay, Rome 4 says you must have pain. This kind of discomfort and bloating that they consider, I mean, it may be there, but that's not pathognomonic of IBS. It doesn't matter whether it is there or not. But then Indians say that this paper, I don't know what evidence he has, but anyway, he claims that pain is less and bloating and discomfort is probably more common in the Indian population. And so we should probably follow Rome 3 criteria rather than Rome 4 criteria. And they also feel that a lot of them are uncharacterized. They're neither diarrheal nor constipating type. And as I said, refractory IBS, if it is the constipating type, you do this. If it is the others, you do all the tests for malabsorption. So I think at this stage, as good surgeons, we should refer them to the medical people to do the tests for, because we are really not into it and we're not really experienced in workup for malabsorption. All right. And that is about IBS. Oh, I've just gone only 10 minutes beyond the time. Any questions from the students first?
Sir, are the subtypes of IBS only this C, D, S, and M, or any other subtypes are also there, sir?
No, they are the ones: constipating, diarrheal, mixed, and uncharacterized. C, D, M, and U.
U.
Yeah. Any other questions, comments? Nitya?
Sir, I wanted to know about that continent ileostomy, sir. I didn't understand how exactly we make that ileostomy continent.
Don't know about it. I think it is almost given up.
Yeah.
Okay,
Okay.
okay.
You read up about Cox continent ileostomy. There are 2 or 3 types, but Cox is the commonest.
Okay, sir.
Okay. Just to know, and as Ravi rightly said, it's of historical importance. A lot of, I told you, no, 70%
Yes, sir.
failure rate. Yeah. 3 operations in the first 1 year. Who wants to do that? Okay. But anyway,
Okay.
read up. Somebody has tried it and it's good to know. After reading, if you have doubts, you talk to me, we will discuss that.
Yes, sir.
Yeah. Because I've actually seen them being done. Yeah.
Sir, any role for surgery in irritable bowel disease? Mostly all papers are saying that it's not recommended, but any role?
Irritable bowel syndrome.
Yes, sir.
Yeah, no role. No role. Okay. If you're not sure of the diagnosis, you may end up with, chronic megacolon, for example. That's not IBS. IBS, as described in this talk, with the specific definitions that Rome 4 criteria, Rome 3 criteria give you. For that syndrome, there is no indication for surgery. Okay. Srikanth, your closing comments followed by Ravi's closing comments, and we'll close the session.
Nothing to add, sir.
Okay. Ravi.
Very good.
So I think I have found that the significant improvement in patients with the constipating variety, giving them prochloride, and I think it's definitely helps them a lot. And the remositron or this one IBSET also works in patients with diarrhea. It has to be given for a period of at least 3 months and then continue if the success is there. I think otherwise you have covered it beautifully, sir. With clarity about both inflammatory bowel disease and IBS. It is an important disease and it forms about 20 to 30% of our practice. So it is better for us to know about it so that, as sir said, we have to initially investigate them and treat them for a decent period of time before you refer it on. And the other thing is, Srikanth was asking the role of endoscopy. And if you do an endoscopy for the symptoms that you described, and if you feel that the duodenal mucosa is atrophic, then mucosal biopsies and gliadin and other antibodies. If you test for them from the mucosal biopsy, then it may prove if there is patient with celiac or tropical sprue, and that may help you to treat them better.
How frequent is celiac disease?
It is more common in the West, but it is probably there in India also. I don't know the percentage.
I haven't seen one, but
it's an histological diagnosis, huh?
Yes, it can.
Histology, yeah.
Okay, all right. Thank you very much. I'll close the session. Good night. Good night.
Good night, sir.